Come sit down here with the. You want to stand here next to me, or what do you want to do? Hello, I think we should make a start. Yes? Hello, everyone. I feel incredibly honoured to be introducing this morning Professor Mundonka as he gives his DAS Professorship lecture. For those of you who don't know him, Professor Mundonka has been a consultant anaesthetist in Coventry since 2001. He's very well known for his outstanding contributions to airway management and postgraduate teaching. He was a co-author of the 2015 Difficult Airway Society guidelines. He was an examiner for the Royal College of Anaesthetists. He's an honorary professor of anaesthesia at Warwick University, and he received the Featherstone Professorship from the Association of Anaesthetists in 2016. He's been a leader in the implementation of human factors and non-technical skills in anaesthesia and has been involved in designing and delivering the SMART course in Coventry since 2009. But maybe I think the biggest compliment is that Professor Mundonka's colleagues, trainees and previous trainees all speak incredibly highly of him, and it's quite clear that he has really inspired and mentored numerous anaesthetists and encouraged them to develop an airway interest. So I'm really looking forward to your talk. Over to you, Professor Mundonka.
Thank you, Fiona. That's a very kind introduction. Thank you, Das. Really highly privileged and honored to give this talk on education. My declarations, I'm president of Society of Education of Anesthesia. All the opinions, views expressed in this talk are my own. I'm a faculty and course lead for structured management airway response course, SMART course. With permission, I have used some video clips and photographs from this course in my talk. So the two important questions I will answer: what is interprofessional education, and how can we incorporate this into airway management and airway training? This is my key message. Those who work together should train together. Perhaps I may repeat this 100 times over the next 25 minutes. That's 4 times every minute. So medicine is complex than we think. Despite of advancing knowledge, science, and technology, medical errors are occurring. And there are many reasons. This morning, we understood few reasons. I'm not going to detail those, but from educational angle, there is a gap in training. Most of the training we deliver is knowledge-based. However, to our day-to-day work, we need clinical skills. Along with that, non-technical skills, attitude, behavior, ability to make judgment, and most importantly, ability to work collaboratively, to work in a team is essential. It's not that easy to deliver these elements as a training. It's difficult to deliver training in these elements in our practice. So this is the reality. In the clinical environment, we all work in a multi-professional team. Ability to work in a multidisciplinary team is a fundamental requirement in medicine. However, both in undergraduate and postgraduate level training, we are trained in silos. Each discipline has their own curriculum, their own training program, with little opportunity to work in an interdisciplinary team. So there is a gap in the training. So this gap in the training has led to suboptimal team performance and errors and poor outcome in healthcare. So this been recognized by Institute of Medicine in late 90s. It estimated that medical errors contributed to nearly 98,000 annual deaths in the United States. So in response to that, Institute of Medicine published this report. And this is to err is human and building safer health system. That means, as human being, in all lines of work, we make errors. We need a system that enables us to do the right thing, and that system that makes it difficult to do the wrong thing. So it recommends establishing interdisciplinary team training programs, such as simulation, that incorporate proven methods of team management. To promote effective team training, train in teams those who are expected to work in teams. So in 2010, WHO published Framework for Action of Interprofessional Education and Collaborative Practice. The aim was to promote a cultural change among healthcare work practitioners so that each healthcare practitioner is competent in working in a collaborative team. What is interprofessional education? So, interprofessional education occurs when two or more professionals learn about, from, and with each other to enable effective collaboration and improve health outcomes. So the key is the learning together and from each other. So members from a team, two different disciplines, attending a conference or a talk together doesn't qualify as interprofessional education. It needs to be more than that. So there should be sharing of knowledge, understanding each other's tasks, understanding how each team members can support each other in performing a task more efficiently and effectively. So most importantly, they should flatten the hierarchy barrier. Can we try first slide or question? I'm interested to see how many of us participate in a multidisciplinary training. First slide or question, please. No. Okay, I think that's good response. So interesting to know that majority are attending multidisciplinary simulation training. Can I have the normal slide back? So thank you. So multidisciplinary simulation is considered as one of the ideal example of interprofessional education. Most important element is the debrief end of the simulation. This is the time where the team members are allowed to freely communicate. They're encouraged to ask questions. They mutually understand each other's roles and negotiate hierarchy barriers. So in education, this then encourages reflection, and as a result of that, the collaborative practice will be developed. So Royal College of Anesthetists published the guidelines for provision of emergency anesthesia and it recommends multidisciplinary team working together in emergency theater should undergo training together, with particular focus on teamwork, communication, and human factors and handover. Now, this is a very powerful message calling for interprofessional education in airway management. Elaine promptly presented for a routine operation following induction of general anesthesia, a CICO situation developed. The team consisted of experienced anesthetist, ENT surgeon, experienced theater nurse, ODP, failed to manage the airway crisis. So it's clear that there was a hierarchy barrier, and team members were not encouraged to speak up, and team collaboration was not existing. NAP4 talks about major airway complications in critical care and emergency department, and recommends a joint training of anesthesia, ICU, and critical care staff. Earlier this year, the recently published human factors guidelines. Again, we need team that work together should be trained together. We have NAP7, the team working in neurosurgical theater, team looking after children in non-specialist centers, team looking after critically ill children, and the team working in the cardiology cath lab. All need multi-professional training. So there is a short video clip to understand more how the team performance can easily fail in performing a simple task. Okay, lack of shared mental model, role confusion, poor coordination between two team members. This is reason for failure. Learning is about reflection. In reflection, has ever my team failed like this? Is this happened to my team? So a couple of case scenarios to explore a little bit more depth. This is a case from recently published book. Patient who had recently had major head and neck surgery. Few weeks later, coming for a peripheral surgery. Anticipated difficult airway. Initial plan in the team brief is awake tracheal intubation. Later on the day, patient comes to the anesthetic room, general anesthesia induced, and supraglottic airway device inserted, and it fails. Fortunately, surgeon was around. I think the recannulation of the tracheostomy was successful. So the key question is, what made to change the plan? So is any of the team members raised this concern? If the team members have been trained together and a culture that promotes patient safety, then one of the team members would have raised concern, and this change of plan perhaps wouldn't happen. This is a scenario published in Closed Claims Analysis. Patient following spinal surgery developed neck hematoma. At high risk, general anesthesia induced, surgeon not present. Multiple intubation attempts and airway management fails. Finally, surgeon arrives, but it is too late. It is mandatory and essential to do team brief involving all members of the team. And surgeons need to be present at this time, and it is standard teaching that in this kind of situations, surgeon is ready, scrubbed, or someone is allocated the role of performing emergency front of neck airway. Again, if any of the team members raise concerns on this an avoidable situation. There are some examples of multidisciplinary airway training teams. This is an emergency airway response team training. Again, it's developed in Boston Medical Center in 2013. Team consisted of anesthetists, ENT surgeon, critical care nurses, and respiratory therapists. They trained 117 members of the team, and using a pre-course, post-course evaluation, they demonstrated that team members managed to understand their roles, communication, and there was a better team dynamics following the similar training. Difficult airway response team training. This was developed at Johns Hopkins Hospital in 2008, aimed at managing airways outside the operating theater. They developed a multidisciplinary airway curriculum consisting of case-based discussions. After developing the curriculum, they developed the team. And the team, again, consisted of anesthetists, otolaryngology, head and neck surgeons, and emergency physicians. So this has improved the teamwork, communication, and improved use of difficult airway trolley. And over a 5-year period, there were no deaths related to airway management, no malpractice claims. DART team performed 360 intubations during that time period. Can we have one more slide or question? Okay, so this is to know, so it's not as brilliant good as the multidisciplinary team training. So debrief is it's not routinely happening as we want it to happen. One more slide of question. Sorry, back to the slide of one. Next question, the final one question. This is, I just need to know, interested in knowing how we pre-allocate roles in our team members in anticipating an airway crisis. Thank you. So there is reasonably good practice. Okay, back to normal slides. Thank you. So this is in Formula One. So this task performed generally, usually within less than 3 seconds. The record being 1.8 seconds. So there are 13 different disciplines involved in performing this task. They all have pre-allocated roles. And they rehearse this many times. They do it in simulated environment. They all have one shared goal, that is to minimize the time spent on the pit lane and complete all the necessary tasks safely and effectively. So based on this principle of pre-allocating role to the team members, we developed this SMART course, Structured Management Airway Response course, which I was involved in since 2009. So this course is designed to train anesthetists, ODPs, and theater nurses together. The course content was designed based on CRM and anesthetic non-technical skills, principles, with the expert help from aviation, BA pilots, and airway experts. There are two parts of the course. The part one involves formulating working team, analyzing various real-life scenarios, and understand how and why we make errors, and further team discussion on mitigating errors. We use tactical decision games to enhance team members' understanding on how they can contribute and avoiding and managing crisis. Subsequent to the second part, the team members undergo multidisciplinary simulation training on high fidelity simulation. So this is the structure of briefing. It's very important to know the team members with their first name. That helps with the closed loop communication and enables to delegate the task easily. We use the 3P model to involving patient, personnel, and plans. The plan should involve allocating specific roles to the team members and the team to prepare for unexpected problems that may happen. So there is a short video clip of a team briefing for a problem that may occur, a patient undergoing spinal surgery in prone position. The team involves anesthetist, surgeon, ODP, theater nurse, and healthcare assistant. They all have pre-allocated role. Sorry, the volume, please.
That can happen now is actually if I put the patient prone and the tube falling out. Right. I hope it doesn't happen, but if it happens, you may have to turn the patient supine.
I hope not, but if that does happen, I'll take control of the head and neck. I'll pack the wound with large sterile swabs and cover it with Tegaderm, and then I'll turn the patient over in the supine position with the trolley on the left side.
I will make sure this does not happen because it was a difficult intubation. However, I will alert the team. We will have the patient supine. I'll ask for the consultant to come, and then I will ensure adequate oxygenation by either a supraglottic airway or a bag mask.
I'll make sure that all the equipment that you've used is still available until the patient goes to recovery. The cricothyroidotomy set is just out there, and I'll help turn the patient.
I will rush to call you from your theatre.
I will get the trolley from outside and help turn the patient, then record time and saturations.
So in case the crisis happens, then team are ready to perform the task according to the pre-allocated role. The key question is, does multidisciplinary simulation training can be translated to the clinical environment? It's difficult to study. There is not enough evidence to answer this question at the moment. The most studies are mostly qualitative studies, looking at pre-course, post-course evaluation, and focus group interviews, understanding the perception of participants. So we surveyed the SMART course participants from past 5 years, and at least 18 participants reported that they had experienced at least one airway crisis and most of these were unanticipated. Various lessons learned from the course have been applied in the clinical practice. So, improved communication, improved situational awareness, and better team performance, use of checklist. These are all been helpful in managing the crisis more effectively. And they've been anticipating problems and being more prepared to manage the emergencies. So this is one of the another course which is recently developed in my trust. Error reporting and analysis of errors is crucial. So record of the analysis of reported incidences of tracheostomy problems helped to design this course. And this course involves training ward nurses, resident doctors in the head and neck department, ENT, and anesthetists together in managing the tracheostomy emergencies. This is another area we need to train the entire team. So all team members should understand their roles in both in preventing CICO scenario as well in managing in case it happens. So the key benefits of interprofessional education are understanding the roles and responsibilities. It helps the shared understanding and to develop a shared mental model. And most importantly, it helps to negotiate professional hierarchies. There are challenges. Multidisciplinary simulation using high fidelity simulation does need time, resources. So it's in the busy clinical environment, it's not always possible. So in a large teaching hospital with 400 to 500 theater staff, we may be looking about 40 to 50 days of training in a year to complete all of this stuff. There is still problem that there are some staff then move out after the training and new staff will join. So this continuing training is essential. So this is one of the solution, most cost-effective model of introducing interprofessional education in the clinical practice. All team members meet together for the team brief and utilizing the 5 minutes of time at the team brief using flashcards. Real-life clinical scenarios can be used. Most important is involving entire team and facilitating free communication between all members, encouraging everyone to ask questions, and respecting each other is more important. So in summary, interprofessional education airway management allows staff to develop essential non-technical skills and behaviors that enhance the patient safety in airway management. Thank you.
Fantastic, Cyprian. Thank you very much. So we don't normally have questions, I believe, after the DAS Professor lecture, so I'll hand you over to Anil and Moomoon.
Talk, as always. So we're going to start the next session, which is because of time reasons. I'm going to ask Dr. Moomoon to introduce the next two speakers. We've got a fascinating lunchtime session.
Hi everybody, welcome to our session on the elective obstructed airway and the trauma airway. I'm Moon, I'm an ST6 in London and I'm currently one of the DAS trainee reps, although I'm actually on maternity leave at the moment. I'm introducing Dr. Ravi Bagrath. He's a consultant at Barts and the London and he's been involved in head and neck and airway work for over 20 years. He's the RCOA DAS Airway Workshop Lead and has been again for over 20 years. He's also the Secretary of the Difficult Airway Society. He's been involved in DAS meetings over many years and he's also one of the co-authors on the DAS 2015 guidelines and the DAS 2020 ATI guidelines. Welcome, Dr. Bagrath.
Thank you very much, Moon, Anil, and Sajay and the LOC for inviting me today. So this is always a bit difficult when you follow the professor, so this will be a little bit of light relief, so feel free to snooze just before lunch. Management of the predicted obstructed airway. So as Tim was saying earlier, not that common. But I'll try and give you a framework of how this works. So I work at Barts and the Royal London. We've had this work here at our hospital for 20, 30 years now. So the hospital has some institutional memory of how to manage these patients. I receive no financial support, so all the views are my own. So no peds, Jimmy covered that this morning, and trauma will be followed by Fauzia shortly. This is going to be a very basic structure. Why is this important? Where should we be doing these patients? Jimmy mentioned that this morning, actually, the where we operate on these patients is quite important, and how we do it in my institution. Why is this important? Well, since the early days of NCPOD, the closed claim studies from the 80s, from the 90s, NAP4 in 2014, and very recently with NAP7, it's shown that morbidity and mortality is still significant when it comes to the predicted airway. Looking at the closed claim studies, both the Canadian ones, the American ones, and litigation against the NHS, it showed that although they weren't common, airway morbidity and mortality was severe and exceedingly costly. These are just a few comments from chapter 21 in NAP7. As you probably saw this morning, airway complications, laryngospasm, airway failure, and aspiration. Examples of patients with predictably higher risk of being inappropriately managed by inexperienced anaesthetists. High-risk group, understandably, are the head and neck surgery group. You saw this morning that nearly 30% of these patients are ENT, nearly 3% are max fax. I quite like this comment. The assistance from a second anaesthetist would have prevented deterioration in cardiac arrest, especially in the predicted difficult airway or in the OH kill intubation. We tend to do a lot of awake kill intubations. Often we don't have a second assistant for us, and it just shows how important that is. And even though there were very few and reduced number of ePhone cases from NAP4 to NAP7, all of those were of the predicted difficult airway, and 4 of those died. So if you ask any of these airway luminaries how they would manage a difficult airway, a difficult predicted airway, I'm sure you would get many different opinions. And that's why there are consensus pieces, there are opinion pieces on how to manage them. And generally people disagree on how to manage it. Some will say, no, absolutely, you need to do a gas induction on these patients. Others, an intravenous anesthetic induction with some muscle relaxants straight away to control the airway is by far the best way to do it. You can't pass by the doors of guys without getting your airway topicalized, and others will say, no, you have to blow as much oxygen as possible, the higher rate as possible through an airway to manage these predicted difficult airways. But if you actually carefully read all these position papers and consensus papers, you find that actually the experts are agreeing. No guideline, you say? DAS loves a guideline. I'll help you out here. So 2019, the awake kill intubation guidelines. There's a little comment down in one of the indications. Awake kill intubation should be considered in the presence of a predicted difficult airway. The 2020 Canadian Airway Focus Group said that actually you should consider an awake kill intubation, but also this double setup. And I'll get onto that a little bit later in the talk and how useful that is. But also last year, in the ASA guidelines, 2022, they said actually the anaesthetist should have a strategy, and that should depend on the skills and preferences of the anaesthetist. So that's the why. How about the where we should be doing these? The problem we have is our resources are different throughout the country, throughout the world. Our hospitals are different. We have large specialist hospitals that have every specialty and piece of kit that you could possibly imagine. We have district general hospitals that may not do that specialty work, but patients may be treated in a specialist hospital, and then in the middle of the night they come back to their district general hospital with an obstructed airway. And there are smaller rural health centres as well. Our expertise differs. I'm talking to an engaged audience here who want to know about the difficult airway. But actually, we have expertise in all manner of subjects. Not only that, but our surgeons' expertise differs. We have some are technically very able, some are happier with a mallet in their hands. But also, even if you call for your head and neck anaesthetist, you might find that actually they're an ear specialist, or they'll be looking at your nose and going, I can do something with that. Or they may indeed be a glottic expert. Same with our MaxFax colleagues. They might be very good dental surgeons or complex orthognathic surgeons. Okay, how do we manage it? So airways can obstruct anywhere from the nasopharynx to the mediastinum. This is one of two physiology questions. I promise it won't get more technical than this. Your airway patency when you're awake is different from when you're asleep, obviously, and it's affected by the changes within the airway. You give anyone a bit of sedation when they're sleeping, you give them sedation, you give them a general anesthetic, your pharyngeal tone will change, it reduces. You introduce that obstruction, extrinsic obstruction or an intrinsic obstruction, you'll get an increase in your resistance and you're going to reduce your airflow and your oxygenation. So upper airway obstruction, so nasopharyngeal, oropharyngeal, glottic, well, how do we manage them? Well, start very, very simply. History, examination, investigation. In one of the previous closed claim studies, there's a comment, a history of previous difficulty is more often correctly predictive of a difficult airway than bedside examination. So take heed of everything in your history. What sort of things do we want to talk about? We want to know about the past surgical history, their previous difficulty, timescale. Is this an acute condition? Is this a chronic condition? Have they had any change in exercise tolerance? Have they had radiotherapy? Often you ask patients if they've had any operations. They'll say, yes, I've had it. They might not mention radiotherapy. They don't consider that an operation. And this may be 10, 20 years ago, but it'll still affect their airway. Are they dyspneic, dysphonic? Do they have dysphagia and OSA? Examine the patient. Look, listen, feel. Is there any overlying hematoma, induration, inflammation? We heard this morning from Becky, have they got a raised BMI? Are there any masses? Palpate the neck. Make sure you know how pliable the airway is. And do they have any reduced physiological reserve? And also, this is going to be reflected, the symptoms are going to be reflected in their obstruction. And that can vary from an inspiratory, expiratory stridor, snoring, and a wheeze as well. But also look at the patient. Do they have an altered breathing position? Can they lie flat? Have they just had a CT and managed it okay or not? Are they tachypneic, accessory muscle use, the sternal retraction and tracheal chug? We're doing all of this. We're doing all of these airway examinations to determine the anatomical predictors of difficulty with laryngoscopy, supraglottic airway placement, face mask ventilation, and emergency front of neck. Also from the closed claim studies. Not acting on positive findings of an airway evaluation figures prominently in cases with poor outcome. Okay, history. Examination, what sort of things are we going to be focusing on? So CT for airway structures, MRI for the soft tissue. Point of care testing, you can do some ultrasound of the neck if you're adept at doing that. But I think the most important and easiest test to do is a nasendoscopy. You can do that in a pre-assessment clinic. You can do that in the anesthetic room. You might find that your surgical colleagues have already done that, but it's a very easy test to do, and especially with some of the disposable smaller scopes that we have now. And that will give you a dynamic image of what the airway looks like. Okay. So once you've done your history and examination investigation, you don't have to treat the patient there and then. Often these patients have got a chronic condition. They may be coming from home. You can perhaps defer them to a hospital that actually perhaps deals with that stuff on a regular basis. I'm not at all suggesting you put an acutely obstructed predicted airway in an ambulance, but also, are these patients, where are you going to be doing them in your hospital? We got called recently to come and manage a patient on our intensive care unit. They said they've got an airway cancer, they're slightly stridulous, they're in the intensive care bed on lots of high flow oxygen. Can you come and do an awake tracheal intubation in the intensive care unit? And actually, it was better moving that patient to the operating theatre because actually the awake wouldn't have worked. The patient actually needed a tracheostomy. but also the time of day that you operate on this. We saw in the NAP7 comments. Sometimes if you've got inexperienced anaesthetists doing it at inappropriate times, they may be inexperienced just because they haven't done many of them because they're a trainee or it's not their skill set. Perhaps if you can stabilize them and move them to the daytime, and then you can have more experience at hand. Okay. Acute obstruction, what sort of cases are we talking about? These generally are time critical, so the foreign bodies, the angioedemas, anaphylaxis. I'm not going to talk too much about bleeding, but the trauma and that sort of things that Fauzi is going to be speaking about in a moment. The chronically obstructed airway is a different beast. So all the symptoms and signs that we were talking about just now, they may not exist. You may go up to the patient and see them on the ward, and they'll be sitting there very quietly. The reason being is that they've developed, their airway tone has been conditioned over months and years to develop that large intrathoracic pressure to breathe through these pinhole airways. However, you give them a smidge of local anesthetic or some sedation, and they have very little physiological reserve, and they will lose their airway very rapidly before you know it, even though they may be a Mallampati 1 talking to you with a very mild stridor. We've been hearing about human factors all morning. The team, your team plan and your plan B, I cannot say how important they are. It is absolutely crucial. I've been working with the same surgeon for nearly 20 years, and we have an understanding, but we are often in a theatre environment with people who we don't spend 20 years working with, and you need to verbalize what you're going to be doing. And I think the key thing is verbalizing when you're going to move from your plan A to your plan B. Your plan A, when we had this intensive care patient 2 weeks ago, was, right, you have one go at putting your suspension laryngoscope in. If you've got a good glottic view and we can laser out the airway, fantastic, we'll do that. If you can't, after that one go, we're going to go for an asleep tracheostomy. And you need to make that clear to the whole team before the patient is brought into theatre. So before they come down, they may have some primary treatment. So we're talking antibiotics, some dexamethasone, some steroid. The evidence for steroids in adults is not as strong as it is in pediatrics, but it still seems to be routinely given. Nebulized adrenaline, the doses, you look at the literature for the doses, and they seem to vary massively. So there's no real exact dose for that. We used to use Heliox, so 21% air and helium. It's 6 times less lighter than air, so you get much less turbulent flow, but you're just giving air. So actually, we tend to use high flow oxygen much more now. Okay, so what about the kind of lesions we're going to be getting? So you can get cancer in all of these lesions. So oral and oral, other than that, in the oropharynx, you get angioedema, you can get abscesses. Tongue base and supraglottis, epiglottitis. Glottic, you can get Ranke's edema, cysts, respiratory papillomatosis, and infraglottic, you can get compression, external, internal compression, aortic aneurysms, thyroid masses. So please try not to take any photos. I've got permission from the patients, but I'd rather not them be all over Twitter. For oropharyngeal masses, so this is a chap on the left and the right with Sturge-Weber syndrome. We tend to sit them up, give them some high-flow nasal oxygen, and do an awake tracheal intubation on these patients. The chap in the middle is a dental abscess, and actually you can see him grimacing. You can barely open his mouth. We actually gave him a little bit of remifentanil. Their mouth opening gets better, but it's still a good way to anesthetize these patients. So this is a patient with ankylosing spondylitis. So as well as having an anatomically predicted difficult airway, he had a physiologically difficult predicted airway with an oropharyngeal cancer. And that was the only position we could get him in to do our direct laryngoscopy, our suspension laryngoscopy. Okay, for tongue base and supraglottic lesions, you need to be quite careful with these. When you give them a general anesthetic, the airway will collapse much more so, and you can find that the epiglottis pushes down, and you can get to doing laryngoscopy. The tip of your blade, if you're either using a direct laryngoscope or a video laryngoscope, can actually traumatize the airway. So I would suggest, and this is just a video, the sort of videos that I get sent while I'm on holiday by my team. They're very thoughtful. This is what you've got Monday morning for you. So this is a base of tongue lesion. This is why we don't really want to be blindly putting in a laryngoscope or a video laryngoscope. And I've been in that situation where you've been as careful as you can, you've put in the video laryngoscope, the tip touches the lesion and it starts bleeding because it's a particularly friable lesion. So be very careful. And this is how we generally intubate our presidents these days. Okay. I mentioned this a few times. they actually provide some good, sensible, clear advice. If you're not used to doing an awake tracheal intubation, it is simple. I think the main reason people don't do awake tracheal intubations, they don't do them very often, and there are many, many recipes out there. This provides you with a very simple, very basic recipe, and you can repeat that. So do have a look at that. Okay, what about tracheal lesions? If you've got a retrosternal thyroid that is causing compressive syndromes, don't just put them off to sleep. This is a lady with a very large thyroid mass, with a very large thyroid compression. And you look at that and you go, well, actually, she might be okay with putting off to sleep and doing some video laryngoscopy. But that's the view of her lying down. And you can see immediately that actually you can't do a plan D. Would a supraglottic airway device work? Maybe, but actually I'm not sure I'd want to manage that lady completely awake. And that's the kind of extent of the tumor that you extend. This is her before, and this is her after. Remember, you're not going to be able to go through the nose very easily if you're using a nerve monitor tube. They're about a 3 millimeter external diameter larger than a regular sized tube. So you want to be putting these in orally. If you look at this gentleman, he's got a very large neck, he's got a very large mass. And so you need to do a careful oral tracheal intubation. And you can see we're using that with high flow nasal oxygen. And generally these cases are absolutely fine. There we go. And these are the kind of large compressive tumors that we see. Okay, what about glottic lesions? This is where it gets a little bit more fun. In our institution, our surgeons tend to prefer a tubeless field. I know some units like to have a small microlaryngeal down. It's a tube down, a 4 or a 5, and they use a small scope, and they do an awake tracheal intubation. We tend to have a tubeless field, so we'll stick them asleep either in the anesthetic room if we're happy that we can control their airway, and we don't just look at them and go, yeah, you should be okay. We've got a plan of how to do that. But if there's any doubt at all, we'll anaesthetize them in theatres with our surgeons around. And we tend to do this with high flow nasal oxygen or with high pressure jet ventilation. And again, these are the kind of lesions that we're seeing. And they're obstructive lesions, and that's why you want a dynamic image, and this is why you want a nasendoscopy, because you get to see what's actually going on. You do a CT-MR of this, and you're going to get quite a different picture. Glottic carcinoma, most commonly squamous cell carcinoma, so in the lining of the vocal cord folds, and they can progress very aggressively, and they can be a very friable mass as well. And they're the most common kind of obstruction that you're going to get. But also you're going to get other forms of glottic tumors. You get pemphigoid, which is an autoimmune disease, lymphoma, recurrent respiratory papillomatosis can be particularly virulent, and these patients come back again and again for airway management. So how do we manage these? This poor gentleman ended up having pretty much every technique I could think of to manage his airway. You can manage these patients, a lot of them, with high-flow nasal oxygen alone if you don't have any more specialist equipment. We tend to use a dedicated high-pressure source jet ventilator. We use a twin stream, so you can do low-frequency jet ventilation as well as low-frequency ventilation as well as high-frequency jet ventilation. And you can either put down an infraglottic jet catheter, you can do a transtracheal catheter, or you can put a microlaryngeal tube down, or supraglottically jet. One slide on high-pressure source jet ventilation. There are a number of ways of administering this. In the old 2004 guidelines, the ManuJet was used for the Plan D. I'd hope after NAP4 that we're not using that very often. There's a lot of morbidity and mortality associated with its use. But there are other jet ventilators around, Mistral, the Monsoon, as well as the Twin Stream. Now, I would suggest that actually it's not as easy to use these. If you're not using them every time, on a regular basis, you can come a cropper a little bit. The Twin Stream is actually quite a nice, if you can hear, you might not be able to hear, you can see we're ventilating at a rate of 12 cycles per minute. So we're ventilating, but also at a rate of 600 cycles per minute. So we're actually oxygenating with that. And that's particularly good in the larger patient where you don't want to lose your PEEP. And actually, they are quite difficult to re-recruit, as we were hearing this morning. This is the second and the last physiology slide. If you look at computational fluid dynamics of the analysis of jet ventilation, it's actually much more complicated than we see. We're looking at, when you're dialing up your pressures, you're dialing up to 1-2 bar. That's 1,000 centimeters of water. That's an awful lot. And you think, well, hang on, is that being transmitted to the airway? And obviously that's not. And what happens is as soon as you get your jet stream or airflow stream comes into contact with air in the glottis, the friction reduces that 100-fold. So actually you're just getting normal pressure, so 10 centimeters of water in the airway. Okay, so once we've managed our oxygenation, how are we going to manage these obstructions surgically? So we tend to do a laser core of the airway, and that's either with a rigid CO2 laser. You can see everything is covered with wet swabs, or you can get flexible CO2 lasers. So actually you can get right down into the glottis, and especially when you've got a view that is potentially you don't have direct line of sight. So you can see with this picture, there's a completely tubeless field. The surgeon is able to get right down to the lesion. And what the surgeon's doing here, he's making these concentric sort of incisions with the laser. And then once they've done that, they put in a balloon and they dilate up the airway from between 3 atmospheres to 15, 16 atmospheres for 30 seconds, 1 minute. And you get a much bigger, better airway. So you can see the balloon being dilated there. We leave it for about 30 seconds, and then you've got an established airway, and it makes it much easier when you're extubating them. So I'm coming to the end very shortly now. Get asked this quite a lot. How do you manage the uncooperative patient? It's quite interesting. We had a patient recently at the Royal London who had a head injury, but also was a difficult airway. Going back to those Canadian guidelines from 2020, they mentioned this double setup. And what they mean by that is get your most experienced operator, and they will go, okay, well, actually, I'm happy and I'm confident that we can do a sleep video laryngoscopy. We'll use a microlaryngeal tube. We'll per-oxygenate them with some high-flow nasal oxygen. Or I'll have one attempt at doing an OHQ intubation, but concurrently, we'll mark up the airway, mark up the cricothyroid membrane, and if we need to, we'll rapidly progress to doing a front of neck. This chap is a barista at a coffee shop around the corner from the college, and he let me take that photo of him. It's not quite anatomically correct, but that's a knife and fork on his neck there. Okay, coming to the end now. Take-home messages. Have an airway strategy. I cannot stress that enough. And discuss this before you bring the patient down to theatre. For the supraglottic and base of tongue lesions, high-flow nasal oxygen and do an awake technique. For the glottic and the subglottic lesions, some sort of high-flow oxygen, whether it's high-flow nasal oxygen or high-flow jet ventilation, and possibly a microlaryngeal tube. And if they're unstable, have your most able operator there, but consider that double setup. And that's me done. We'll see you all in London next year. Thank you very much indeed.
Thank you very much for that excellent talk, Ravi. That was really useful and lots of strategies for us to take home to our own practice. I'm going to move on to introduce our next speaker, who's going to speak on the trauma airway. And we have Dr. Fawzia Mir. She's a consultant at St George's, an MTC in London. She's an extremely experienced complex airway and trauma anaesthetist. She's also the treasurer of the Difficult Airway Society. She was the principal organiser for the London DAS meeting in 2017, and she will be again for 2024. And she's also a co-author on the ATI guidelines from 2020. Welcome, Dr. Mir.
Thank you for the kind introduction, and thanks to the local organizing committee and Sajay for inviting me here today. It's an honor to be part of this great meeting. So in the next 20 minutes or so, I'm going to talk to you about a traumatized airway, the whats, the whys, and the hows of how to manage it. So it's going to revolve around both the causes of the traumatic or traumatized airway and incidents. Why is it difficult? What management options we have, followed by some examples. I have permission for using patient videos and photos for teaching and training, but not for social media, so just be mindful of that, please, before taking pictures. Just to say, nobody's paid me very much to do anything. All that I've done is my own doing. This is where I work. It looks very nice, clean, serene, calm place from the outside. Inside's a totally different story. For those of you who've been to St. George's, it's mad, it's chaotic, it's super busy at the best of times. But that's how we get really interesting airway cases, mostly related to trauma, as well as some airway obstruction acute cases as well. And our team gains valuable experience from managing these. So a traumatized airway can be looked at from the site of the obstruction or bleeding. So it can be bleeding within the airway, outside the lumen, or from other structures such as GI bleeds. Or it can be a iatrogenic cause of bleeding, either anesthetic related, surgical related, or an external trauma to the airway, which can be both penetrating or blunt. Whatever the cause is, it is important how we look at it and how we make a management plan for these. In the closed claim analysis, about 6% of the claims were respiratory. And if you look at the distribution of these injuries, laryngeal injuries most common and temporomandibular being least common, most of these happened in non-difficult airways, especially things like temporomandibular joint injuries. They happened 100% in those cases where the airway was not deemed to be difficult. Why that's important is because mortality from these injuries is very high. It's almost 15 to 20%, especially if you look at the subgroup of perforations from these injuries. Our management plans, our strategy in dealing with these cases has evolved over the years. Our serious airway complications hasn't yet quite decreased. And that's maybe because we're getting higher grades of ASA patients, more difficult comorbidity-wise patients as well, along with the traumatized airway to manage. If you look at the numbers across the different injuries from both the ASA closed claim analysis and compare them with the NHS litigation-based authorities, they're very similar, especially with the percentage of injuries you get in laryngeal, pharyngeal, or esophageal injuries. Coming back to external trauma or iatrogenic kind of injuries, the direct traumatic injury is very rare. The most commonly quoted incidence is less than 1%. It can be blunt or it can be penetrating. The bigger studies that have been done with over, like as an example, I've chosen this Canadian trauma center study with over 12,000 patients. The incidence was less than 1% in this study, but the mortality associated with these was quite high, especially if you look at blunt airway trauma, which carried a mortality of 36%, which is why it's important to think about these cases and make a plan before we attempt to manage these cases. So the external trauma can be max fax injuries, laryngeal injuries, they can be tracheal injury or compression due to anterior neck hematomas, contamination of airway because of either blood, vomitus, or in cases of trauma, teeth or foreign body. It can be a delayed airway compression because of trauma-induced soft tissue edema, which happens a few hours later. Or it can be displacement of the retinoid cartilages or vocal cord or other cartilages in the larynx. The vast majority of iatrogenic injuries happen in cases where ET tubes are used. The video laryngoscopy has been associated with upper airway trauma. Mostly in the cases that have been reported were associated with rigid stylet use or multiple attempts. Injuries from use of supraglottic airway devices, very rare. Life-threatening airway trauma was rare in NAP4, but there was one case reported of non-fatal trauma with the use of bougie. Regardless of what or why we get these injuries, what is important to remember is that blood in the airway, whether surgical or trauma, is highly associated with complications, especially at emergence, and that can include deaths. So looking at NAP4 data, there were 5 cases of aspiration of blood related to anesthesia. There was 1 death, 1 front of neck access, and 3 led to ITU admission. 2 were primary events. Both happened in recovery following upper airway surgery. There were prolonged periods of impossible ventilation reported, cardiac arrest, misinterpretation of capnography, and a large blood clot was removed eventually more than 10 minutes later. There was a case of airway obstruction in recovery secondary to a retained throat pack as well. 3 were secondary events. There was a blood complicating a lost airway during inhalation induction, severe surgical bleeding, and airway trauma associated with laryngeal mask insertion. There were all sorts of ages involved, 4 adults, 1 child. Happened both in all types of surgery. So it happened in intraoral surgery, one in max-fac surgery. They happened in all phases of anesthesia, 1 at induction, 1 during maintenance, and 3 in recovery or emergence. So it can happen to anyone at any phase, and which is why extreme vigilance is important. What was concluded was that aspiration of blood, although it's less hazardous than aspiration of gastric contents, but large blood clots into the trachea can cause complete total obstruction and can lead to fatal outcomes. The recommendations were that anaesthetists should all be educated in the prevention, detection, and management of blood clot aspirations. And where a capnograph is flat, indicating absence of ventilation, and the tube therefore deemed is either displaced or obstructed, and there's been blood around in the airway, active measures should be taken to exclude an inhaled blood clot. So why is it difficult? Why do we all worry about bleeding or traumatized airways? Well, it's difficult because it has direct and secondary effects. Direct effects being impaired glottic view, making your laryngoscopy and intubation attempts difficult, an increased difficulty to pre-oxygenate, complications such as laryngospasm, a blocked airway, and the fact that our usual go back to airway aids such as flexible bronchoscopes, their view is impaired, so they may not actually work in these situations. Secondary effects being cardiovascular instability, such as in major bleeds, an added complication to an already difficult airway, which is hard to manage. It's very stressful for the anaesthetist. Human factors are involved. There's a high risk of failed intubation and ventilation. The chances of performing an emergency front of neck access are high. And more so, DAS algorithm for difficult airway may not be applicable because face mask ventilation may not work, excessive bleeding, supraglottic airway device may be difficult to insert or operate. Topicalization may be suboptimal if you're attempting to do an awake technique. And then extubation may be challenging as well because of laryngospasm, ongoing bleeding, an unsecured airway, and problems with the patient with extubation. So there are some pre-intubation surgical measures you can use, specialist tubes for variceal bleeding, you can use intranasal packs, embolization if you've got the facilities in the hospital, antifibrinolytics, or a direct compression of the bleeding vessel if you can see it. There's a risk of hypoxia, there's an increased risk of aspiration of clots, major hemorrhage, and a risk of difficult airway in an otherwise straightforward intubation. So what we need to plan is our usual plans A to D. An important concept which I learned while reading about this was Professor Cook's, he's written an excellent book chapter amongst his millions of other book chapters, which mentioned a composite airway failure concept. And I found it really interesting because when you're making a plan A to D, it's all well and good saying, I will do A, B, C, and D. But if you take into consideration the chances of failure, your rescue strategies need to be carefully thought about because they have a higher chance of failing as well. So for example, when tracheal intubation fails, mask ventilation may fail in up to 10% of those cases. And when mask ventilation is difficult, the risk of failed tracheal intubation increases more than 10-fold. So whatever your rescue strategy is, you need to be carefully planning that out before you choose your primary strategy. Human factors come into play. Team working, good leadership, good communication is required to manage these cases. Whether you do them awake or asleep depends on what kind of patient you have, what kind of expertise your team and yourself have at the time you're faced with such a patient. So you can choose an awake tracheal intubation if at risk of failure or difficulty in intubation is recognized, the patient's compliant, and there's an awareness of difficulty using airway aids such as a video laryngoscope or a fiber optic scope. You can use a GA technique, making sure you have full preparation for a rapid sequence induction, a double suction technique, including SALAD, which we'll talk about in a minute, and 2 capnograph devices, just if in case of one blocks with the bleeding, you have a second backup plan. I'm going to mention a few of these cases which happened at St. George's in the few years or so, just to give examples. So this poor gentleman upset at his ex-wife and understandably got stabbed, came in very upset, very agitated. Due to the unfortunate position of the knife, which he attempted to pull out before coming to the anesthetic room, he broke the handle, and then the knife got stuck even more, and he couldn't open his mouth or talk, which added to his agitation. He was very reluctant initially to have an awake a fiber optic technique, but when we talked to him about it and explained the process and all that, he eventually agreed. As you can see, we did put in a high-flow nasal oxygen device to give him pre-oxygenation or peri-oxygenation during the process. It was one of our trainees who attempted this intubation. He was given a fair dose of remifentanil for sedation, and also to manage his anxiety and his behavior as a result of the drugs which he'd taken to control his pain before coming to us. So it's one of our excellent trainees doing this intubation, and as you can see, the high-flow nasal oxygen usage meant he didn't desaturate or anything. We used remifentanil to calm him a little bit and make sure it was all communicated to him. It does go in eventually.
Might do a bit of a cough.
There we go. So if you notice where the knife is situated, just the one point to make is ergonomically we need to plan well for these cases. So the sharp edge of the knife is facing the top part. So when you're attempting your fiber optic scope, navigating it through the nose and the airway, you need to be careful that the operator doesn't slice their fingers off against the knife, because it is a bit precariously positioned. It all went well in the end, and he even gave us a thumbs up before going off to sleep. I always say exercise is bad for you. We get lots of people who are either exercising or cycling on the roads and come into us. This poor gentleman was a cyclist going to work and smashed against the back of a van, got severe facial injuries. His nasal bleeding was quite pronounced. And in fact, in the end, we gave him a personal Yanka sucker to hold and suck himself. We decided to do an awake video laryngoscopy on him and anesthetize the airway as we do for an awake fiber optic technique, except we sprayed the base of the tongue with an extra squirt of local anesthetic. He did tolerate it well. And as you can see, in this instance, our anesthetist is standing in the front. You can do it standing on the side or at the back, which is a normal position as well. But then, if you look at the ergonomics of your position, if you're standing at the back, your arms will go around the face of the patient, and that might be a bit claustrophobic. So as you can see, it did go in. He tolerated it really well, and there were no problems with this. This is a case of a 22-year-old gentleman who was speeding a bit, and it's a whiplash, not a whiplash, it's a seatbelt injury, which he sustained. So on the first look, it looks like it must have surely damaged some internal airway structures. And but if you look at it carefully, if you ask him to talk and swallow, you can just about make it his gross structural integrity is intact. Like you can see the whole larynx move, or the thyroid moving up and down, and he could swallow well. What we did for him was we did a double technique. So we put in a video laryngoscope and used a fiber optic scope alongside it, so that we could actually see where we're going and if there are any holes and perforations or tubes past that damage. Sometimes if we're not 100%, or the airway looks a bit tricky, but there is no option except to do a GA technique, then we mark the neck just in case, and have the surgeons ready at standby in case if we need to do an emergency front of neck access. And it gives a reassurance to the whole team. The plan is communicated to them as to how many attempts we're going to use with what and who's going to do what in case of an emergency front of neck access. There's some cases which come in as a delayed presentation. So initially the airway management had been fine. They tubed, packaged, sent to ITU. Like this gentleman came in 4 days later with an innocent looking request of a tube change. They said, we can't suction properly. Can you please change the tube for us? We think they might be a little bit, it's a bit narrow and it's not the appropriate size. So when we inspected the airway, we first saw something in the oral cavity, and on further exploration, it turned out there was actually quite a large blood clot, almost like a whole sausage coming engulfing the tube and the NG tube. So this is just to say that if there was an accidental extubation, or if this this patient was extubated without proper precautions or airway assessment, it can actually be a fatal event leading to complete airway obstruction. We advocate an early tracheostomy in these cases, especially if they've got upper airway bleeding and a risk of clot formation in the next couple of days or 4 or 5 days before they're extubated on intensive care. The presence of airway contamination with either blood or vomitus, they've both been shown to decrease the rate of first attempt intubation success, regardless of what device you use. So you can use a fiber optic, a video laryngoscope, a Macintosh blade. Your first time success rate is reduced. What we should remember from a bleeding airway is there's always more blood internally than externally, so expect that. Patient positioning is very important. Identify and mark your cricothyroid membrane. Have a strategy for your oxygenation, fluid resuscitation if needed, things like bougie, double section, salad technique, which is this video demonstrates it really well. So you put in a Yanka sucker on the left-hand side in the premolar sort of position, put in your airway device, either a video laryngoscope or a Macintosh blade, and you attempt intubation with constant suctioning of the contaminated stuff coming up from the oral cavity. I like this checklist because it kind of gives you a framework to hang things on. So preparing the patient, equipment, the team, planning for difficulty. You need to have thought about all aspects of your airway management in these cases to make it a success. Post-intubation wise, suctioning down the ET tube prior to assisted ventilation, if your oxygenation levels permit, is very useful. Discuss and agree on a planned strategy for extubation. Remember, extubation is always planned. It should always be planned. So you can make a plan, discuss it in MDT fashion, consider transfer to ITU for stabilization of bleeding, and then make a plan, a strategy to take the tube out. So in summary, bleeding airways are very challenging. Good teamwork and focus on human factors is essential to manage these. Try to use familiar techniques always. The senior-most anaesthetist should secure the airway. An MDT planning prior to managing these patients is essential. The concept of composite airway failure should be kept in mind when you're making your plans A to D. And remember that blood in the airway will impair the use of routine airway equipment. So have something else as your secondary device available if you need. And an early plan D strategy should be discussed with the team, and all the steps should be agreed as to who's going to do what, is going to get what equipment. Do you have everything at hand, whatever you need or not? Happy to take questions then. Anybody who makes eye contact with me this year will have to listen how great and fabulous the 2024 meeting is going to be, and how important it is that we all attend that meeting. Thank you.
Thank you to both the speakers. It's always such a privilege to hear talks by people who actually do it and are real experts in their field. So thank you for that. Questions. We've got 5-10 minutes of questions if anybody has a burning question that they would like. just to get things going, excellent. Is there a question up there? Could we get a microphone over to? For those that didn't hear it, the question was, for patients who are pre-assessed beforehand, particularly by nursing staff, what should we be looking out for?
So I can only really comment on how we do things in my hospital. So what we tend to do for that is that we have kind of two-tier pre-assessment. So if a patient is flagged as having a predicted difficult airway, so the nursing staff are taught how to do Mallampati and ask the patient whether they've had previous airway surgery, etc. But if they're deemed to be difficult, and often these are the patients coming for head and neck surgery, so they're on an elective ENT or MAX list, they are then seen by an anaesthetist in pre-assessment, say the following week, and it's usually an anaesthetist who has some experience in doing head and neck surgery. I think that's really crucial. When I was doing stuff at UCL, and Anna Fowler used to do pre-op nasendoscopy. And I think actually that's probably one of the most useful investigations to do. And then you get real-time dynamic images of what the airway is like. I think that's key, actually. I don't think there's it's a multi-step process, but one thing needs to trigger the anesthetic airway assessment. Does that answer your question?
Good. I think there's a question over there.
Yes, thank you. My name is Umair. I'm one of the anaesthetic consultants at UHCW. Thank you for your fantastic talks. This question is for Dr. Mir, actually, as a trauma anaesthetist. I was very pleased to see that you said marking the front of the neck before starting or embarking on any sort of airway procedure. Just in your experience, would you mind sharing whether you suggest that our surgical colleagues are best placed to rescue the airway from the front of the neck, or whether we are? Thank you.
Thank you very much. It's a very interesting question. So it kind of depends on your individual team's patients and your circumstances. So I won't say a surgeon should do it, and I won't say an anaesthetist should do it. What I will say is the most experienced person in that team should do it. So you might have a surgeon who's an F2, and you may have a consultant anaesthetist who regularly does either transtracheals or does trachees on intensive care, or has more recent experience of doing them. So the important thing is not to say it's a specialty-based thing. In my view, I think it's an experience-based thing. So whoever in your team at that time is the most appropriate, most experienced person to perform it should be doing it. The other thing to consider is if it happens as an unexpected thing, then generally it may so happen that the operator doing the first intubation, who's recognized that an emergency front of neck access is needed, is too stressed at that time to actually perform the procedure, and he may delegate it to one of his team members to actually perform the procedure. But all of this needs to be planned within the team.
Thank you.
Great. Someone's standing up there. Is that a question, or are you getting ready for lunch?
I have a question.
Just in there.
Hi there, my name's Seb. I'm one of the Airway Fellows down in Derriford. As a keen Airway Fellow trying to get my nasendoscopy skills up to scratch and do it on patients with potentially difficult airways, could I ask you all what considerations should we think about in terms of contraindications, or when shouldn't we do it, if there's a risk of making the airway worse?
So when we shouldn't do a nasendoscopy preoperatively? Is that what you're asking? Sorry,
exactly.
I didn't quite hear. Okay, well, presumably anyone with nasopharyngeal tumours and lesions, things like that, pregnant patients, you can still do an oropharyngeal endoscopy. So that you don't have to just do a nasal endoscopy. The scopes we have now, as long as you're not traumatizing the walls of the nasopharynx, the ambu scopes are very good. They're a 3mm external diameter, they're a 30cm long disposable scope, and the ENT surgeons tend to use those more and more often than their own reusable kits now. And I think as long as you don't cause any trauma, just don't hit the walls as you go down and shove it very painfully down, you should be okay. But it's the same with anything. I think even with, if you've got bleeding issues, as long as you're careful, you've topicalized the nasopharynx with Otrivine, cophenolcaine, you can do that. But you don't always have to do that. But I think there aren't that many contraindications for that. But pregnancy just definitely being one of them.
Okay, there's two more questions, I think. We've got one over here and then one over here.
Krish Radhakrishnan from Commentary. Thank you, Ravi, for a good presentation, and also Fauzia. My question is regarding patients. We often use these modern gadgets. We got video laryngoscope and ambuscope and so on. But I have managed at least 2 patients who were presented to A&E with a tongue that was swelling out of their mouth from a severe reaction, and there was hardly any breathing. I could do intubation of these patients using an age-old Miller blade, which we often forget and often comes in very handy because it's a paraglossal approach, and we can get in past a bougie and get a tube in. Just a suggestion that it is something that we often forget, but old equipment sometimes comes in very handy in a crisis, and it is often important to consider those as well. And also, just may I make a suggestion that when we are dealing with an airway problem, we often are not concerned about the diagnosis as to what exactly it is. We are often dealing with a problem, whether it is trauma or otherwise. We are just trying to get the patient oxygenated. That should be the focus and not the diagnosis as such. Your opinion on that?
So I think the first question was straight blades, Miller blades, role of, in 2024, who's using them? Is it a useful technique?
So I have got some experience in using straight blades when we had them available. They've been taken away. And I fully appreciate your view on that. Epiglotoscopy, or when you lift the epiglottis with the straight blades coming from an angle, it does help to access the airways. But the problem is, in our current armamentarium of the airway equipment that we have generally available in our hospitals, it's not available 100% of the times. The training opportunities with those are limited as well. And when you're faced with choosing a device with these problem patients, I always say I would choose the device which I'm most familiar with, which I use regularly, rather than taking something out from, from a box of equipment which I use maybe once a year or something. So it depends on your expertise. And yes, as you said, there's no problem with the device. It's the experience that we have in using that device that determines whether we should or shouldn't use it in an emergency like that.
Great. There's a question just there. Thank you.
Hi, my name's Chris. I work at your neighbouring trauma centre at St Mary's. A question for Dr. Mir. Thank you for that nice video of awake video laryngoscopic intubation. My question is about which video laryngoscope is most suitable. I note that you were using a AirTrack, a channeled blade, and most of the descriptions I've read in the literature are with channeled blades. We're thinking of getting rid of our AirTracks, which means we wouldn't have a channeled blade at all. Would that be a mistake if we want to consider awake video intubation?
So I can't say use X or Y device. It depends on what you have available. But what I find in my hands, that a channel device is good for, or easier for, awake video laryngoscopy, because you don't need to then introduce a stylet. which is an added risk of either injury or uncomfortable or pain for the pain-inducing process for the patient. And that's the reason why, in my hands, I think a channeled video laryngoscope is better for video laryngoscopies. But I'm sure Anil does lots of wake VLs, or Ravi, you may have different ideas.
We have fewer and fewer air tracks, actually. I think as long as you kind of follow, again, exactly what Fauzi was saying, use the device that you're most familiar with. I think that's absolutely key. When you're doing the awakes, as long as you follow your tube just follows the blade down, and perhaps doing it with a bougie first. I think in that video you had a bougie and then a tube, didn't you? Yes. It does take a little bit of practice. You're more likely to slip out than with a channeled device, but I agree with you. The only other issue with the air tracks is they're quite a bulky device, aren't they? Yeah. Whereas some of the reusable CMAX glide scopes that we can get have got a nice thin blade, and I think they are sometimes easier and less traumatic to use. But I think you just have to get adept at whatever you're using.
Okay, we've got 2 final questions and then lunch, so 1 and then 2.
Thank you. My name is Jan from Denmark, and I was just comment on the use of blades. I think it's an interesting discussion and also a matter of technique, because actually what we use is actually the hyperangulated blade, especially when we're doing the hybrid techniques. And I mean, it's a matter of sedation, topicalization, and also using the technique. And we have tried to invent in Denmark more and more that using MAC blades compared to hyperangulated blades is actually 2 different techniques. And to go in the midline with the hyperangulated using a fiberscope is quite good, and I think it is totally comparable to using the air track. Yeah. So it's just commenting on the blade technique.
Yeah.
I think the other thing about using a hyperangulated blade is that it's second nature for us when we put in a Macintosh blade to lift. Yeah. And I remember the very first couple of times I'm doing an awake VL, your natural inclination is to lift, and you're not topicalizing against that, and it's very uncomfortable for the patient. Exactly. Yeah. But with a hyperangulated blade, you don't need to do any lifting, and you get your view immediately, but you need to use a bougie from the outset.
Yeah.
Okay, final question.
Thank you for the fabulous talks, all of you. I come from a very resource-poor setting, Sri Lanka. In fact, I just tell a little anecdote before I ask my question, if you don't mind.
Actually, we're running short on time.
I come from a place where we had endotracheal tubes, but no laryngoscope. We got, donations. And the anesthetist, who was a medical officer who had been sent to a dispensary, basically, had to intubate a patient with a same speculum and a torch held by a laborer. So that's the sort of place where I come from. I used to get patients who get attacked by sloth bears, and I want to know, is there any place, so basically their face is ripped to shreds, and we don't have the facility for awake intubation. Is there any place for retrograde intubation, is my question.
For
retrograde intubation.
Yeah, I mean, that reminds me, I did remove a slide, which I did have on retrograde intubations, because I don't use it normally in my clinical practice, so I'm not the best person to answer that, but that technique is well recognized. And there are experts I know in the audience as well who've used it. So if you're familiar with it and if you use it regularly, then yes. If such a patient comes to me with a smashed up face and there's, a video laryngoscope or a fiber optic is likely to fail, I'll probably volunteer or opt for an awake front of neck access. But it depends on what you're faced with at that time, and include what expertise you have in your team at that time.
Thank you.
Wonderful. I think we'll close this session down. Thank you very much to the speakers. Thank you.